The world of BPD has such few role models that I feel very strongly that more people should talk about it. There's hope and there's light at the end of the tunnel.
So there's a genetic vulnerability that almost everyone with borderline personality disorder has. It's not just your environment gone wrong. Two people could grow up in the exact same environment and still develop something that is different.
There are a lot of people claiming to be psychotherapists and counselors who are doing things that might be unhelpful.
Hello and welcome. I'm very happy to be guest hosting this episode of the Zen-Brain. When Shruti asked me to guest host this episode on BPD, I was a little nervous because BPD is a topic that is very fraught. But I come with the comfort of my two guests. One is Aditi. Aditi is an ex-colleague from my work before. She works in mental health content creation and is a person with lived experience. Aditi has spent a lot of her time understanding her mental health and working on how she can educate others in the mental health space, which is why she's very apt as a guest for this podcast. Ashlesha Bagadia, I'm sure most people watching this already know her. She's my co-founder. The PARC is a psychiatrist and a psychotherapist, has her practice at the Green Oak Initiative. When I was thinking of BPD, I couldn't think of anyone who had a better grasp of this topic than her. Not just because of her, 2 decades of experience in the space, but she's constantly been updating herself on borderline personality disorder. She's trained in mentalization-based treatment and is a practitioner and also the only supervisor in India in the modality. So I feel like I'm in good hands in this conversation, and I just have to ask the good questions, and I'll be taken along pretty well. So welcome you two. I'm going to start, sort of jump right in with your origin stories. I'll start with Ashlesha. You've worked on borderline personality disorder for years now, and you've also, famously said in a lot of our own marketing material, said there is something very, very rewarding about working with borderline personality disorder. So can you tell me a little bit about your practice in general and about why this is a space that you feel so passionate about?
Thank you, Pavitra, and thank you to Zen-Brain for bringing this podcast together. As you mentioned, this is a topic very close to my heart. And I guess, when you were asking me this question, I was thinking, should I embarrass myself and reveal what my first kind of impressions were of BPD? So as a junior trainee, when I first started training in psychiatry, this was many, many years ago. And at that time, my exposure to psychiatry first began as a formal trainee in the UK. And it was in the hospital systems. And borderline personality disorder was already starting to get associated with stigma, as the difficult patient. And, we don't want to see those people. And I didn't know anything about it. And I know we had to do training in psychotherapy and take on a long case. And all I would think was, I hope I don't get someone with BPD, not knowing anything about BPD at that time. And it turned out that the person I did get may or may not have BPD, but she definitely had trauma. She definitely had emotional dysregulation. And now when I look back, she probably had a lot of the criteria that would have met with borderline personality disorder. But I didn't have any of those negative feelings that I thought I will have when I was seeing her as my patient, right? So when I saw her, maybe because I didn't think of her as with BPD or without BPD, but now when I look back, I was thinking, what the hell was I so scared about? And what is all the stigma about? And I think, I don't know if my interest developed then. I think we just in training got exposed a lot overseas. Borderline personality disorder does become one of the frequent presentations in hospital systems, but they don't end up staying for very long. And I must say, even in most advanced healthcare systems, they don't really get a good exposure to the right kind of treatments immediately. I think it's changed a lot over the years, but even overseas, they were getting it wrong many times. And I think it's only when I started doing more specialized training, when I started working with attachment-focused therapies, when I started working in doing specialized training in psychotherapy, and I actually worked with a team that did dialectical behavior therapy. And initially it was to get some skills. But when I started working with that team is when I really immersed myself in working with people with borderline personality disorder. And I could see, maybe because I was a little bit more experienced, but I think I was also surrounded by people who had the right skills to be working with them. And they spoke differently. They didn't have the same language, that, oh, they're like this, they're attention seeking. So even the team spoke of the vulnerabilities, the difficulties that people have. So when you start looking at it like that, and that's how it should be, then I realized that, they've just got a very bad reputation for no fault of theirs. And when you start applying the right skills, approaching them in the right way, then you get the right response. You get to see them get better, and that's when I started getting interested more and more in working with them. And of course, when I came back to India, I realized that we are here now where UK was when I was there 20 years ago. So it's almost like this is the right time for us to be talking more about this, reducing the stigma, because I can see that happening here. The health professionals still talk about it in terms of what I used to hear, my colleagues talk many years ago. So, and it's only ever, my experience has only got better in terms of from what I experienced from the people who are suffering with it. I've never had a bad experience. If you think about how people talk about people with borderline personality disorder, I've never been a recipient of that bad experience. I've only been a recipient of watching them suffer or them not knowing how to manage. And so I do feel that if we change our approach, then we can really help them. So yeah.
Thank you for that. And I think that gives us like a good platform to move to Aditi. And Aditi, could you tell me a little bit about, maybe go back to your own experience with your mental health issues and where borderline personality disorder came in? What happened with the diagnosis? What was your journey like?
Yeah, thank you for having me on the podcast. And it's nice to be reunited with Dr. Ashlesha, who will feature in my story as well. So I think my mental health issues began when I was 12, 13, which is about 2-3 years after I had moved to Bangalore from Chennai. And I think the main component for me, the big trigger, also I thought, was bullying in school by a couple of teachers in particular. So I think that I was depressed when I was 12, 13, but of course I didn't know that at the time. It's only later that I thought, oh, okay, that was an episode as well. And, my mom got me some help, and I was lucky to have parents who didn't sort of try to beat it out of me or something like that, right? So they took me to a counselor, and I was put in a different school and for my 10th standard, where I actually started to improve. That's when I started writing. My English teacher there encouraged me to write, and I still write for a living. So, and I think for a while it got better, but around college in Manipal, when I was 21, I suffered a couple of traumas in succession and started drinking heavily. And, I was using alcohol to cope. And I think until 2013, I knew I had mental health issues, but the narrative around was that you just have to be strong and, you can do it. And I don't want medication because how can medication help? Not taking mental health as a health thing, not taking it seriously. So I ignored it for that long. And honestly, now when I look back, I think, how did I even get through so many years without treatment? In 2013, I lost my mom. And following that, I had a pretty serious nervous breakdown. That's when I went to see my doctor, Dr. Sandeep Deshpande, who's still my doctor. But the joke is that he's the most consistent man in my life. I think Dr. Sandeep really helped. I think he saw also the inhibition that I had to seek treatment. And I started seeing Dr. Sandeep in 2013. And there were moments of improvement. It's a process, right? So I was sort of maybe improving, managing better with the medication for sure. In 2016, I got married and got separated the same year. And, with BPD, there are a lot of issues with relationships. So that was very evident throughout my life, but it also made me feel like a monster. And I think after a couple of 2017 is a blur, because I think I just drank through the entire year and I started struggling a lot with suicidal ideation. And I even attempted a few times. And after one of these attempts is when Dr. Sandeep told me, I think I have a diagnosis for you. Um, After 5 years of seeing him, borderline personality disorder, and he told me not to Google it. Of course, I didn't listen. But yeah, that's how I was diagnosed. And I was immediately put into mentalization-based therapy with Dr. Ashlesha, who I think treated me, I can say, for 1.5 years, because I think we had some
we did a group.
follow-ups as well.
Yeah.
Yeah. And yeah, I think, I like to see it this way, that if the treatment worked, the diagnosis was right, because that was the start of, I think, my journey towards recovery. After, I remember the last day of my MBT group session was my first day at Weizmann Foundation, where Pavitra was my boss. And yeah, I think life just kind of turned around. After that, slowly, you'd think it would happen, in a big way, but there were many stepping stones. MBT was one, Weizmann was one. And in 2020, I stopped drinking. And that really, my recovery just sped up after that. And I can say I am definitely 70% better than I was before. I still struggle, of course. And I'm sure through the course of this, you'll find out how. I have a weird, ambitious dream to maybe be a role model for other people with BPD. There is hope. There's a way out. I know it doesn't feel like it, and nothing I can say, I say will convince you otherwise. But if you keep at it and trust the process and find specialists who are as passionate about treating BPD as Dr. Ashlesha, definitely there's hope.
The world of BPD has such few role models that I feel very strongly that more people should talk about it loudly and say, there's hope and there's light at the end of the tunnel. And for that, I definitely admire you and thank you so much for doing this. Now, for some context setting, and I want to come to you, Ashlesha. What is BPD? How do we understand it in the context that we know? And I feel like it's one of those diagnoses that is constantly changing. How common is it? There seems to be this sense that more women are diagnosed with it than men. Can you do a little bit of a myth busting for us to understand where do we stand right now as we know this diagnosis?
Thanks, Pavitra. And I must commend Aditi, in just the clarity with which you talk about yourself is so heartening to see. And of course, I would love to take credit for it, but I know, and that it's also, just the amount of effort it takes and to be able to make yourself vulnerable and to put in that hard work and to trust. I think that's the hardest bit. So I think that's one of the first things that is a difficulty that a lot of people with borderline personality disorder experience, but it's not classified as a symptom. Right? So borderline personality disorder is essentially a disorder which affects the personality of someone. But because traditionally personality disorders were considered as something that someone is stuck with for the rest of their life, it was because of the treatment availabilities were long drawn and were focused only on managing risks and things like that. So anything which comes with the idea of personality disorder is understood as something that has been set now. Like once your personality is formed, you're stuck with it, and that's how you're going to be for the rest of your life. And so that paradigm was there for the longest time. and it still exists, I think, to some extent and hasn't been changed a lot. But we have definitely seen that the progress of personality disorders treatments in general and borderline personality disorder in specific has improved so much that we are no longer seeing someone with a diagnosis of personality disorder meeting that criteria, like 5, 10 years down the line. So we also have the opposite problem where someone comes back to me after 5 years and says, I don't think I have BPD. I don't have any of the symptoms anymore. And I'm telling them that, but that's because you had the treatment, right? So the whole way of looking at the personality, borderline personality disorder itself has changed. But traditionally, the way to understand the disorder and who meets the criteria, as it were, has not changed so much. So that has stayed the same. The understanding of how borderline personality develops has more or less stayed the same. And we are seeing more and more evidence that, yes, it can, the symptoms can present differently, but the fundamental symptoms remain the same. So the first thing that happens for many people, of course, there is a genetic vulnerability. Now, the genetic vulnerability could be if someone's parent had anxiety, someone's grandparent had depression, which I'm guessing almost all of us will have something or the other in our genes, which we never know of because our ancestors not treated that commonly. So there's a genetic vulnerability that almost everyone with borderline personality disorder has. It's not just your environment gone wrong, which is why it's two people could grow up in the exact same environment and still develop something that is different. So you might not have two siblings with borderline personality disorder, for example, right? So there is a genetic vulnerability, but that then gets matched with what we know of as invalidating environment and traumatic environment. So in the upbringing years, if there is and it need not even be something that has been deliberately done. So one of the early myths, if you want to bust your myth, one of the things that would commonly be thought of as if someone has borderline personality disorder, they must have had abusive parents, right? That's the kind of common understanding that everyone jumps to, and we know that's not necessarily the case. They could have had very well-meaning, understanding parents, but their experience might have been of feeling invalidated. Or they might have not felt invalidated from their parents, but they may have had it from elsewhere, like bullying in school that Aditi mentioned. So experiencing invalidation need not only come from parents, but it can also impact. It's how that it impacted on that person. And when this starts happening very early in someone's life, their ability to then trust and feel comfortable with someone, be vulnerable with someone, starts getting affected. So, and if you think about someone growing up, what we need in our lives as we're growing up is to be able to feel safe. So then we take risks and then we achieve something and then we feel comfortable, oh, I can do that. But if you can't trust people enough, and I'm guessing if you have an environment in school where you get bullied and you're scared, you're less likely to raise your hand and answer a question. You're less likely to make a mistake in the lab or something like that, right? So your confidence starts getting affected. And if this starts happening in your formative years, what then can happen is that it starts making a lot of people feel like they are worth nothing. So the core thing that a lot of people with borderline personality disorder end up feeling when they're at that time and their identity is being questioned, that's when they feel like they have nothing to offer, they have nothing worth giving. And if you think about someone growing up in an already kind of difficult environment, it gets reinforced, right, that they have nothing to offer. The other so one of the symptoms of borderline personality disorder is finding it hard to attach securely with people, like Aditi said, relationship difficulties. So their ability to have them having a history of difficult friendships, difficult relationships comes from that. Not because they are terrible at making them, it's because they find it hard to trust, or they trust too easily and then they get hurt. So there is a lot of things that goes wrong in the relationships. The other thing that can also happen is if they are, for example, if someone experiences a trauma and they go and tell someone and they don't get taken seriously, they tell someone else, they don't get taken seriously, because that's what happens, unfortunately, in our world. So then they might, be more vocal, more vociferous, and then they might get taken seriously. So someone who's in an invalidating environment also learns that only if I shout and scream, I'm going to be taken seriously. And it's unfortunate because that's not how they would have intended to develop. So what we end up seeing by the time we end up seeing someone with personality disorder, and they say, oh, she's, always screaming and shouting, or he's, always crying, or so it's almost like that becomes their problem rather than thinking of it as like they didn't get taken seriously. So this is the only way they know how, right? So they develop this emotional dysregulation because um, it didn't really happen at the right time. Like, toddlers have emotional dysregulation, teenagers have it, but they get the environment that supports the regulation. So the symptoms you end up with by the time you say you develop the personality disorder, usually around adolescence is when it gets worse, right? When you're questioning your identity, all of us are at that time. So it's when someone with borderline personality disorder might start presenting with lot of dysregulation in the mood, suddenly feeling okay, suddenly feeling not okay, not very sure of themselves, having relationship difficulties, and unfortunately for a large percentage of people also using something as a quick fix to manage their symptoms, right? Either using alcohol or drugs, smoking. For some people it could be sex, for some people it could be hurting themselves. So these are all coping mechanisms which again get attached as symptoms. She is having indiscriminate sex, he is just cutting himself, so those symptoms which actually stem from them just trying to manage this distress that they don't know how to, these are the symptoms that they have. In India, just to bring it to context, I suspect, we don't have evidence to back this, but I suspect we've always had perhaps comparable numbers of borderline personality disorder to elsewhere, but it's never really looked into. Also, our systems are very different to other countries, right? Like in UK or US, for example, if someone is hurting themselves or someone is suicidal, they're likely to go to the emergency department. They're less likely, or they were less likely to do that in India. They're more likely to just, it gets wrapped up quietly, or they don't even think that a doctor can help them with something like this, right? It's definitely changed a lot in the last decade. So there is a much more understanding that if I'm hurting and if I'm hurting myself, or at least someone else thinks you're hurting yourself, this is not right, we need to go to the doctor. So the presentations to the hospitals have increased. And I don't know if that is understood at, okay, this person has a problem, or it is still being understood as a problem person has come to us to trouble us and we don't know how to help them, right? But they were not presenting so much to the mental health services or general health services. They're presenting a lot more. And definitely, we are definitely seeing men present as well. It's still less common than women, but it's definitely there. And I suspect it perhaps was there. But our paradigm of how, just all of us as a generation and as a species, how we are presenting ourselves as men and women is also evolving. We are no longer, stuck in silos. Girls can behave in sort of masculine ways without necessarily being called tomboyish anymore. Like boys can express themselves without them being called as sensitive or girly. It still happens, but it's less common, right? So I think men are becoming a little bit more in expressing themselves, which is why we are realizing, okay, they have difficulties. They are also vulnerable, right? So that I think is a paradigm shift in how gender is getting represented, and that's why we are seeing it more commonly. Also, I think what would happen previously, because of the roles that men would have got typecast in. I mean, I know women have suffered, but also men get typecast in roles. So they their trajectory of personality difficulties ends up going in, or ended up going in different ways. So now there is more sort of, it's keeping in line with almost they have the freedom, let's say, to fall apart like someone with BPD can. In previous generations, they may not have had that. So we might be seeing more of representation in men, and which is a good thing, I suppose, that it's not something that is, again, there is no blame that all women are like this, or there's no blame that why are you being so sissy? If we can be understood as there is an underlying distress that has developed over the years, and if we can offer the right kind of environment that can be overcome, then it's equally good for anyone with any gender.
I want to take another minute to get into this gender bit, simply because that's a topic that that's been in conversation for a while in the BPD circles. So my understanding is that we are saying that now that men are a little more free, at least in urban settings, to express themselves, you are seeing people present with symptoms of BPD more often. Do we have an idea of what it is like across the world? Do we have any studies on what the prevalence and how they, is there a difference between how men present and how women present?
I mean, it's still, I think, not that easy for men to present and express themselves. And the way they might express is still in say, a problem-solving way. So they're judgmental of themselves more because they can't fix it. So that's one thing that I see men often present with. And I also feel, because I run groups, one of the difficulties I experience on behalf of the men, I suppose, is that they are a little, underrepresented. So the group is full of women, and there'll be like one or two men. So I feel like sometimes the services itself, getting help itself, can be quite intimidating, because they're surrounded by perhaps, women who have been harmed by men, who feel very strongly about how they were abused by men, and rightfully so. But they are having to express that in front of a man. And the poor man hasn't done anything wrong, but is also trying to express what went wrong for him. So I feel that underrepresentation makes it harder for them to perhaps, express exactly what they're feeling. And so they may be experiencing invalidation from the services also, from doctors and therapists also. I do know, just historically from other countries, that there is more representation of substance misuse in men. So alcohol, drugs is more in men. Violence is more in men. And not just, I'm not talking about domestic violence, but, just in terms of violence with general public. And because of the violence, sometimes they get misdiagnosed as antisocial personality. Or narcissistic personality, because it seems to be like, oh, you're a man and that's what it must be. So I think that's something that can happen. Also, because we know one of the fundamental difficulties, attachment, and how men represent or express themselves in terms of an attachment is by doing something for that person, or it's changing, but it's still more like that. And how women might attach themselves is very different as well. So how they might talk about their attachment is also very different. So it may not get picked up as, oh, this person has had a vulnerable childhood and perhaps had a disorganized attachment with their caregiver, because of how they talk about their caregiver. So it's changing a lot, but I think just in terms of how they express themselves might be an issue. And I'm not saying it's not an issue for the women. I know that, one of the early groups that we ran, perhaps the one just after yours, Aditi, we had a request from our group members that, if you have a man in the group, then I won't be able to join, because I've just had, and to be fair to her, she had horrendous experiences at the hands of caregivers, at the hand of, uh, medical system. So at that time, I was in a dilemma. I was like, how am I going to handle this? Fortunately, we didn't have any men coming in during that intake. And then I was thinking, okay, next time I'm going to have to strengthen the person who's saying no men in the group, rather than, banning the man in the group. And we did that. And I know it was hard for the other women. And I know it was hard for that. We've had two groups now where we've had, one group had a boy. I mean, that was an adolescent group. So I'm saying it's a boy, but he was 17, 18. And we had a transgender. So in a way, it was a little bit balanced, and not all girls. But the second group, we had two men, which was more an adult group, and one of the men didn't continue for too long. So that the man who continued till the very end remained the only man in the group till the very end. And, it's hard to balance these things out. But I'm guessing this is their experience, I suppose. When they go out into the world of therapy and talking about their experiences, this is what they're experiencing. And also, I could see that there are women in the group who were perhaps getting triggered by a man in the group. And it's about balancing that as well. I don't know if I've gone off track from your question, but yeah.
This is very useful, and I think gives us a large number of perspectives on how this can be seen. Like almost everything about borderline personality disorder, many things exist in the gray, and that's sort of, I think, what I really want to do in this podcast, to say that there are no blacks and whites in this conversation in many ways, and let's sort of like put all of it on the table and see where we want to go. And that's sort of true for our listeners as well, to say that there isn't a set path and there isn't a very defined way of how you're going to experience borderline personality disorder or somebody in your family, or there isn't a set way of treatment, which we'll also go to in the second half of this conversation. But coming to diagnosis, and I think that itself is a very gray area. What does diagnosis entail? And I'm going to come with a few of some anecdotes from my own experience, from my social circle, people who've been diagnosed too soon, people who haven't, who've had multiple kinds of diagnosis, who've first been told that they have bipolar disorder, then moved to borderline personality disorder, and then moved across, right? And this is very, very confusing for both the patient and their family. So I thought we could spend just a little bit of time just to understand what's happening here. How does a psychiatric diagnosis really happen? How, what's going on? And then, of course, I'm sure Aditi has her own story, and but it'll be great to hear. Let's put the facts on the table first, to say, what does diagnosis entail? Do we have a problem of overdiagnosis? We hear that a lot. Is that true? And then, of course, this entire thing of changing diagnosis every 2 years, you have something else, and where do labels really sit in this world? Are they important? How do we wrap our heads around this?
No, it's such an interesting question, and I feel like I probably was a little bit very medical in my early years, where I'm like, someone comes to me, I have to interview them, do an assessment, and come to a diagnosis, right? That's like basic medical stuff that I have to do. But I think now I have changed a lot in how I approach it, and I feel like when a good psychiatric assessment is done, it's actually to understand what's going on, and that should be the premise, right? Does this symptom complex that is coming to me, does it have any links to this person's upbringing, genetics, history, and is it sufficiently explaining what they are experiencing right now? And has that been described in anywhere else before? Right? So if it's been described anywhere else before, then it looks like they meet the criteria for this, and there is an understanding of them having this particular condition. But in mental health especially, and that's one of the reasons why I chose this specialty, is that no two people with the same diagnosis are alike, right? Like someone with an appendicitis will have the exact same symptoms, and like doctors can go through say 100 appendicitis without really knowing the nuances and differences between each of them. Whereas I feel anyone with a diagnosis of depression, as simple as depression, OCD, or anxiety, or as complex as borderline personality disorder, is completely different to someone else. Some of the symptoms will match, but they always have to be looked at as an individual. I understand that you meet these certain criteria, but for you, this is the difference, this is the similarity, these are the things that will help, these are the things that won't help. And really, that is how it should be done, in terms of when you're assessing someone to see what is it that best explains what's going on for you, what do we know, and maybe we don't know some things, and from what we know, what can help you. So really the benefit of diagnosis, and like we heard from Aditi, right, it's only after she got diagnosed, then they say, okay, let's try this. So for me, the benefit of diagnosis should be to get the right kind of help, rather than say, oh, you have this problem, something's wrong with you, right? So even a label of, we know that in India, it's still stigmatized, like diabetes can be stigmatized. Even though there is so much everyone understands about diabetes, it's still stigmatized in many small towns and people who are not educated. So I feel like the labeling and the stigma comes from others, and that's the problem with the diagnosis. If the diagnosis is given with the view to say something's wrong with you, and it's almost like this is a hopeless situation, we can't do anything about it, then any diagnosis can be stigmatizing. So, and I feel like it needs to be addressed based on what the person sitting in front of us is expecting. So I know that for some people, and I had that experience. If I tell them that they have a diagnosis of borderline personality disorder, because of the lack of resources or how they end up going to get treatment or where they are from or who's referred, they might be in a hospital ward, for example, that diagnosis is not going to serve any purpose. That's just going to end up everyone, stigmatizing them, because I may not have reached to all these other people who I have to educate to tell them that, okay, just because they have BPD doesn't mean that something's like, completely broken or whatever they think about them. So I feel like sometimes I have to give them an understanding of the condition, and having a diagnosis may not be very helpful. And it's really based on what that person requires from me at that time. But I know many, many people have told me that when I tell them that, okay, it looks like some of your criteria meets borderline personality disorder, or, more like complex trauma, you've experienced a lot of complex trauma. And so what you're exhibiting is symptoms of that. There is a lot of relief. And I don't know, maybe it'd be nice to hear what Aditi's experience was. But many have told me they feel relieved because it doesn't mean they're the only person behaving like this, that they're crazy. If there is in a big fat book, a DSM, there is a label and a name that says, this is a condition, that means many other people must have had it. That means it's a condition that's recognized, that I'm not just behaving badly or I'm not crazy. So I feel like the stigma around diagnosis is what we have created. And it really needs to be catered to what that person is asking of us and what will benefit them. Will they benefit from being given a diagnosis, or will they be benefiting from given a formulation of understanding what your problem is? But ultimately, it should be done only if there is a pathway afterwards. Like, it's not to say, oh, you have BPD, go away, right? It's to say, okay, you have these things, what next? That should be the conversation that should happen. And just in terms of answering your question, usually the best way to arrive at a diagnosis is talking to the person, listening to the person, right? So a good history, it could be a psychiatry or a psychologist who does it, but just talking to them and really understanding the sort of getting into what happens when they're upset, what happened to them, and talking to people that they trust as well. So getting information from other people. Sometimes using standardized tools can help if they're not able to give you the whole history. But and also not diagnosing them in the first interview. Like you see them for 1 hour and then you say, okay, you have this, that, and the other. So seeing them over a period of time, at least 2-3 times, and then coming to an understanding is the ideal way of doing it.
Right. I'm going to, for the sake of our viewers, I'm going to ask, how long has it usually taken for you to arrive at a diagnosis, especially one as complex as borderline personality disorder?
I would never, even though sometimes I have a gut feeling, I never diagnose in the first interview. Sometimes 2 or 3 interviews is when I'm, consolidating, confirming.
Yeah.
Many times I feel my judgment might get impaired because someone comes to me and says, I have BPD, right? And I've had a feeling from the beginning that they don't, right? So it's almost like then I have to gather evidence to say, you have a lot of things, but you actually have this core strength. That means that you're not like, you don't meet the full criteria. So often I'm trying to convince people that there are other ways that explain their condition. But
Right.
usually it takes 2 to 3, if I'm assessing, doing a full psychiatric assessment. But also there have been times when it's taken much longer if they've presented so I see a lot of perinatal women. So I see women when they're depressed postnatally, and at that time the priority is just to help them out of the depression, right? So at that time they may be presenting with a very severe depressed episode. The priority is their care, the infant's care. So it's only when the depression is lifted much later that we then start seeing the underlying vulnerabilities, and then we might recognize, okay, there is a personality factor. So if I'm assessing someone who presents without any other comorbidities, it may take 2 to 3 interviews. But if there is something else going on, then it may take much longer, and it's variable.
What is the confusion between, do they exist on a spectrum? Is it a cluster problem with the bipolar disorder and borderline personality disorder? Where is this confusion coming from?
The confusion is coming, I think, from the mood dysregulation. So someone with a borderline personality disorder may have difficulty in regulating their mood. So if they get upset, they might get so upset. See, the reason why they got upset may not be wrong, or what they feel is definitely not wrong, but the intensity may not match with what's going on. So they may feel very angry, or they may feel very sad, and it may be a small thing by someone else's standards, or they may be trying to mask something, so they allow themselves to feel very happy very quickly. That gets misunderstood at, oh, this looks like a manic episode. You're manic, you're depressed. So traditionally, bipolar disorder is when there are episodes, long episodes, which last for weeks. Sometimes it can last for months, but weeks definitely, of very low mood that is staying low for a long period of time. It's not up and down. Uh, and or accompanied by episodes of what we call at the other end, either hypomania or mania. Now, in terms of how it's viewed, so these conditions, bipolar disorder, which is a mood disorder, schizophrenia, which is a psychotic disorder, obsessive compulsive disorder, which is a neurotic disorder, they are on one axis, as it were, right? So they are what happens to perhaps all of us away from our baseline. And it's a periodic, severe thing that happens. But there is the axis too, where our fundamental things are there, like our personality, our intelligence. So personality disorder sits on axis 2. Someone with a personality disorder can have mood swings, but they can have enduring feeling of sadness. And someone with a personality disorder can also get bipolar disorder, but it's not on any spectrum together. It can sit together comorbidly. Someone can have two of these conditions, but they're two very, very different conditions.
Yeah.
But now I'm going to go to Aditi and I'd like to talk to you about your diagnosis. What was your reaction when I think to Ashlesha's point on different people receive diagnosis differently, and I'd really love to hear from you how you received it. You've also spoken. You also talk about how you interacted with your diagnosis very differently over a period of time during your journey of understanding yourself. Um, I'd love to hear about all of it.
So I was diagnosed at 32 years old, which is pretty late. And I think the first thing that Dr. Sandeep told me was not to Google it. I obviously did not listen. But when I Googled it, and also I just wanted to add that after my successive suicidal attempts is when suicide attempts is when Dr. Sandeep diagnosed me. But he didn't do it right as soon as he knew about it. Because when I asked him, when did you know? He said, I actually knew a while ago, just after you had, attempted. But I felt you were too vulnerable at that point for me to tell you. I didn't know how the diagnosis would impact you. So he took his time actually before telling me what I had. And I think that's great and kind of goes into the point that Dr. Ashlesha was making about not branding, the person with the diagnosis, right? The reason why the diagnosis is being provided is for something else to happen after that, and that's not the end, right? But yeah, when I got my diagnosis and I Googled it, firstly, when I got a diagnosis, I was happy, right? Initially, I was like, oh, okay, there is a reason that all of this is happening. And because at that point, I think I was just under the impression that it was recurring depression and maybe like a generalized anxiety disorder or something like that. And I think it was like, okay, there's a diagnosis, so now we can do something about it, right? So first emotion was, yay, this is great. And then I Googled it. And I saw, there are those 9 symptoms, right? And I had 8 of them. And I was like, okay, so this happens to other people, like you said, right? So, okay, I'm not this, it's a common human experience. So I'm not out of the ordinary. There is like a place where I belong or whatever. And so I think initially I was quite happy. Then I started to see one was, I think, the suicide rate that stood out, that I think at that time it was 10% of people, kill themselves. And then I guess it made sense in a way that because I was so unhappy with life, and every time I tried to make it better, it just would not stick, right? Even if I was putting in 100% effort into doing things, like I was getting treatment, right? For 5 years, I was already on medication, and I was, I am hardworking. You know, have even when I have not been able to get out of bed and things like that, I have wanted to keep working. And I know that that sort of drive to live or survive is there, and I can feel that. And but at the same time, it's like the world is just constantly crumbling around you. And I understood that 10%, right? It was like at that moment, I was closer to the 10% than the 90% who survive.
Yeah.
And so that's when I think a little bit of the sort of gloom of the diagnosis started to set in. The first reaction was, oh, okay, so no wonder I'm suicidal, because this is the end game, and that's how I'm supposed to end up. And this was right after my separation. And then I found support groups for BPD on Reddit, but I also found support groups for people who have been in relationships with people with BPD, right? And I ended up in that side of the internet where BPD is, described as the psycho ex-girlfriend. And yeah, then I remember sharing all of this with my ex-husband, and I said, was this me? Like this, like, was I like this? And he said, this is not you, and you may be presenting some of these behaviors, but the people who are writing this are people who've been hurt by these people. So it's a very biased opinion. And I suggest you stay away from this part of the internet, because it's not going to help you. And, listen to the doctor. Don't Google it any further. He's found this MBT thing for you. Do it. Right. And I did it. I trusted the process. I think my first 6-7 sessions of MBT, I was absolutely skeptical about it working, because at that point, the only good mental health professionals that I had interacted with were Dr. Sandeep and a counselor that I was seeing at the time called Jaya. And everyone before that was just awful, right? Like, I've got the worst advice possible. Like, everything, everything to sort of blame my behavior on, except, maybe something possibly being wrong that can be corrected with treatment. Like, someone told me to stop listening to heavy metal music. Someone told me to stop having casual sex. So, I think up until then, getting help had not put me, had not done me any good. It just made me feel worse about myself. And I see that the internet also does that. I see that the media also does that, right? Like, I haven't seen a single person with BPD being represented well in TV shows or movies. Girl Interrupted is one of the movies with BPD. Then there's Crazy Ex-Girlfriend, written by someone with BPD. I get how the character acts the way she does. I understand it. And I know that there are people who are presenting this way and behaving this way. And I absolutely empathize with them. I know what's going through them, but I also know that they don't want to be that way, right? They don't want to be behaving in a way that they can't control it, or doing something when they emotionally, you know, uh, uh, dysregulated, and then regretting it the next day, right? Because they've done something they can't take back. And I've done those things as well. So but I see that when I see the way it's represented in media, it's not from an empathetic lens, right? Because the takeaway still is that, oh, if I date someone with BPD, she's probably going to stalk me later, or, she's going to overact. Like the best relationship that I've been in, we're no longer together, but we're great friends still. I remember him telling me one day that, yeah, I mean, BPD is just basically you're overacting all the time. And I said, that's one way of putting it, sure. But again, it's invalidating, which is where the problem started in the first place. So this does not help. And I mean, he was receptive to what I said. So that was nice. But it's just, I feel like you're already dealing with the disorder, which is difficult. And then you're having to defend yourself, and the disorder, the diagnosis, everything, because the world is so misinformed about it. If you look at the Wikipedia of people with personality disorder, a major portion of them are criminals, and like Jeffrey Dahmer is on the list. And then you have a percentage of them that have all killed themselves. And and then I get it, no, when I look around, I don't see someone like me, successful or doing well. I don't see these stories because, one, maybe there's few of us. Because when we try to get the help, it's not there. When we try to do things, we are silenced, we are stigmatized as, being crazy, being psycho. And like, maybe we need to ask why, what happened in the gap of care where all these people on this Wikipedia list ended up being like this, right? Becoming criminals, or not living life to the very end due to, suicide or overdose, which again comes back to substance abuse, which is a big part of BPD. So yeah, I feel that for me, the diagnosis was good, that it streamlined into treatment, but I also see that I'm surviving because of a lot of privilege. I have parents that had parents that really understood me. I can always fall back on my dad, my sister. Like the support system that I have is incredible, and I don't think everybody has this. Also, I can afford the treatments. My medication alone costs a pretty big percentage of my salary, and I can imagine that this is like a lot of privilege is what's keeping me alive. And it also goes to say that there needs to be like a very serious intervention in terms of access to mental health care, and removing the stigma around mental illness, like not taking somebody who's having so much trouble with emotional dysregulation to a temple to be exercised, as opposed to, going to the doctor. So yeah, I felt great about my diagnosis at first. Then I came across all of this dark stuff, but I think at that point it was just everybody around me saying, this is what there is to do, and do it. And I wasn't very successful with my attempts, which now I see as a blessing, but it was the only thing there was to do, to go for the MBT group sessions. And then that ended with me getting my dream job. So there was no stopping at that point. But yeah, the diagnosis was difficult. And I think in therapy after that, I've always had to be reminded that I'm not just my BPD. So a lot of the times I might react strongly to something, and I'd be telling my therapist that, oh, I need to reel this back in. And she said, that's a situation where it's okay to react this way, right? And you don't need to kind of force fit yourself into your BPD diagnosis either. So I see how diagnosis can also, you may reinforce it back to yourself and say, oh, I must be like this because I have BPD, right? But also an understanding that is just to understand what you're dealing with, and how to get help for you. to move forward. I also feel that the way my BPD manifests has been different when I was drinking and after I quit drinking. I feel I have a little more self-awareness now to sort of see how my emotion can go from 0 to 100 in seconds, right? Over like the silliest of things. And yeah, it's different, but the underlying sort of um, thing is the same, in the sense it's the degree that's different. It's the amount of sort of no, I wouldn't say control over it, but more like tolerance to it has changed. Yeah, like to just, because I think a big part of it is, again, you mentioned dialectical behavior therapy. And the only person I like idolize with BPD as the only role model I have that who also has BPD is Dr. Marsha Linehan, who you know founded the dialectical behavior therapy. And a part of dialectical behavior therapy is radical acceptance, which is where you accept that you are going to feel this way. And I think that's important. We do that for physical illness, right? We accept that, okay, now that I have diabetes, I'm going to have to do this a certain way. We don't think twice about it. And I think with mental health, it's pretty much the same, especially with BPD. I know that because I have BPD and I have trouble with relationships and emotional regulation, I need to be a little bit aware of how quickly I get attached to people, how giddy I feel about some people. You know, sometimes I meet some people and they're just like really awesome. And I remember feeling like this about Pavitra when I first met her as well, that, you know, man, I want to just be her best friend right now, right? But that's the kind of, I guess, behavior that people feel very intimidated by. They get a bit creeped out by it, which is where the narrative of the whole psycho thing or whatever comes up. But the person who's doing it is probably not doing it out of malice. They're not, right? Because for them, there's this thing that makes me feel so good in this whole dark world where everything has been horrible. And obviously, I want to surround myself more with it. I want to just like envelope myself with it, right? So it's coming from that vulnerability and inability to control things. And I think accepting that, you know, I have these tendencies and tolerating it, thinking, oh, you know, I really like this actor and I really like the work that he's done and I love this movie, and I'm going to just let myself enjoy it in that moment, right? I get that I'm getting all these feelings like, oh, I want to go and, you know, have to some way tell him how I feel about it. But to understand that that's not actually going to result in me feeling better, and just sort of accept that, yeah, I feel like this right now and it's going to go away. It's temporary. And I mean, that's what radical acceptance is. But that particularly has helped me a lot uh, to kind of even deal with the diagnosis itself, right? Yeah, I have BPD, but it's not the only thing about me. And there is treatment, and you do it, and you trust the process. You do things by the book. Sometimes it works, sometimes it doesn't, and you move forward. I like Dr. Ashlesha said, the diagnosis has to be followed up with the work. Otherwise, then it's just a label again to put yourself in the dark side of the internet. Yeah.
Thank you, Aditi. And I'm just constantly amazed by how articulate you are about your experience and in your context of our own relationship and at a workplace. I think I will say that I felt nothing but warmth and an extreme ability to rely on you. I felt like you're one of my most reliable colleagues. So I think you should definitely walk away from this conversation knowing that we haven't exchanged that before. But I do want to continue with your experience, and I think that's one of the reasons why this sort of worked, and it made sense to have you on and talk about your experience. Is your journey of finding help and treatment, and it's been a long one. You said before you found your healthcare team, it was a process, and after that, it's also been a personal process, right? There was the healthcare team. There was also many things that you did for yourself. You found your group, you found your support system, colleagues that you work with. Could you sort of take those who are listening to you a little bit through that? Because I feel like there were ebbs and flows in that journey. And so
Yeah.
it wasn't as pretty as it came out to be. And I know that you're now making this fantastic content. You're stitching and you're making wonderful things with your hands, and it sounds also lovely on the outside. But there was a lot of work and there was struggle. And I think I would like to hear everything, the struggle and the joy and all of that came with this journey.
I, in fact, remember Dr. Ashlesha herself telling me that you had a very solid childhood. So I think, the BPD should be easy to treat. And it was only recently, like 2, 3, maybe not 2, 3, maybe about a month ago, where I had a difficult therapy session where I actually sat and unraveled my childhood. And the thing is that every time I thought of my childhood up until a month ago, I would look at it from the lens of a 38-year-old, right? So I'm thinking, like, yeah, I mean, I moved from Chennai to Bangalore, and my first night in Bangalore actually wasn't in my home. It was in a relative's house because my parents didn't want me to miss school. So they brought me here 3 days early. They dropped me off at this relative's house with my granddad, and they left. And I ended up falling really ill because I had asthma as a child, and Bangalore weather is not really conducive for that. And I had a fever so high that I hallucinated and things like that. So my first day in Bangalore or my first night in Bangalore was not pleasant. And I always thought that, what's the big deal about that, right? Except that I always looked at it from the lens of an adult, whereas for a 10-year-old, that's pretty big. That's a pretty big change to begin with. To move to another city, that itself is hard to deal with. And secondly, for this to be the introduction to the new city where I constantly fell ill, I didn't know the language, I had to make friends, and that's always difficult no matter what age you are in. And it was, I think, to look back on it with more empathy than I did in my previous years. I understood that, okay, I contextualized it. Yeah, I had a difficult childhood, not at the hands of my parents. Of course, they were wonderful, as wonderful as parents can be. Not like not like a fairy tale set of parents. Actually, my parents did end up getting divorced when I was 17. So there was definitely trauma along with the way, right? I lost, I think from the year of 2003 to 2018, every 5 years, somebody died in my life, somebody very important. A friend, my first was a friend. And then in Manipal, I uh, lost what happens in BPD called a favorite person, where you just have one person you sort of idealize, and you feel like you love them with your entire soul, and like the universe was made for you to find this person. It actually is that intense. And so I lost my favorite person to a freak accident, and I couldn't attend his funeral, which is a major step in grieving. And that's when I started to really abuse alcohol. And that's the first time I actually saw a psychiatrist. My class mentor, he took me to a psychiatrist, and the psychiatrist, right off the bat, in the first, he said, "Oh, you're just an alcoholic. You need to just stop drinking." He was bang on. I was an alcoholic, definitely. I still am. And he said that, but it was the way he said it, right? Like there was no, I'm sorry, you've been through so much and you're coping with alcohol. None of that context. It was just, once you quit, drinking, everything will be better types. And I was like, you don't even know me, like, what do you know? You like, so obviously, because again, invalidated, I didn't take the advice. And I guess my life would have been very different if I just had quit drinking at that point. I was also assaulted in Manipal. And after that, I got into, two abusive relationships, one after the other. Like I knew the first, when I was getting out of the first abusive relationship, I thought, wow, this person that I'm going to start seeing now, the second person, is rescuing me from this abuse, right? It's just another kind of abuse. And I think that's also common for people with mental illness in general, not just BPD, where you are vulnerable to abuse, because there are those gaps in your self-esteem, and you are just a vulnerable person at that point, right? Because there's so much up in the air, and it's very easy for someone to take advantage of that. And over the years, lots of people did. When I quit drinking and got into therapy in 2020, I, began to see, as I strengthened myself with therapy, I began to see that there were so many toxic people around me. And these people, I think when I started to get better, all my relationships got better, right? Like with my father, with my sister, people were able to trust me more. I wasn't, saying, oh, I need money for something and then spending it on alcohol. I wasn't lying anymore. I was being genuine. I was communicating better. I was doing better in life with my things. I was able to like keep my house clean. I was able to function on a daily basis. Laundry is always done. Things like that, right? The small things. And when those improved, everything is around you is improving, except like 2, 3 relationships, and you wonder why. And then if your relationships are starting to struggle when you're getting better, then you're not the problem there, right? And so I started to see that maybe these relationships were holding me back also in a way. When I started basically becoming stronger, standing up for myself, it started to get rocky. So I I think it's not just been about finding the right help, but it's also been about being aware of things like a mental diet, who you're friends with, what are you browsing on the internet, in terms of, okay, you're watching the news, but are you also watching reaction videos where people are just angry with each other and forwarding them? And, who's forwarding you this stuff? Do you want to have a conversation with them and say, hey, I don't want to see this triggering stuff anymore? And just becoming sort of aware of where all of these things are coming from and trying to change those things a little bit at a time. And I think a lot of this was from therapy, right? Because it was only when I could, I guess, when all those things up in the air are taken care of, where you can start to see the little things and iron them out, right? And it's been a very long journey. Like I think MBT itself, during MBT is one of my friends, I lost a friend of mine to, I mean, suicide. And he had borderline personality disorder as well. And yeah, that was difficult. But I think with MBT, one thing was that in group, you are practicing what the outside world is like, having those conversations and having those conversations with other vulnerable people. And also, I felt like everywhere I went, I have not belonged. But the first time I really, really belonged was in that group session. And it was eerie that, like, because until that point, I really thought of myself as a very unique person. And I am a unique person. But I felt unique because of my struggles. And then I met people who had similar struggles, and who, some of them were in their recovery ahead, some of them were behind. some I agreed with, some I absolutely disagreed with, some I liked, some I didn't like. And it was the world being sort of replicated in this little room, right? But in that, unlike the world, in the little room, I'm allowed to be myself and be honest and not judged. And I think we should make the world also like group session, group therapy sessions. But yeah, my first few therapists, like counselors, and this is like, you want to avoid medication, you want to avoid the psychiatrist and the psychologist. So you try to find counselors who are operating near your house. And or my mom took me to a homeopathic doctor, and who's the one who said I should stop listening to heavy metal. And I still listen to heavy metal, by the way. I don't think that's the problem. So, and yeah, so I think it's more the denial of, can mental health care really help me, that I think really stood in my way. Like I said, the first psychiatrist I went to gave me, I mean, he had the diagnosis on the dot, but the way he approached it was not, very great. And also I know that when you see a therapist, it's very rarely like a love at first sight situation. And, you may not feel comfortable with the doctor for whatever reason. And I remember when White Swan Foundation shut down its content team, and I was devastated because it was my dream job. And I wondered who would hire me now, right? Because the only people who would understand the accommodations required by a person with mental illness will be a mental health organization. So I think that I was very devastated that day when I found out that, White Swan Foundation would be shutting down their content team. And I didn't feel like talking to my therapist. And she insisted. She said, no, just call. It's okay if you want to stay silent on the phone. You can answer a few questions here and there, but don't miss the session. I said, I don't want to do video. She said, fine, we'll just do a phone call. And I did it. And it was the first time I was uncomfortable talking, but I talked anyway. And I feel like that was the moment where I realized that this is just like getting a breast exam done, right? Like, it's uncomfortable. It's especially uncomfortable if you have painful lumps, but in general, you're vulnerable and it's clinical. There's more than one person in the room most of the time. And but you have to get it done. You just have to do it, right? And you're doing this because you have to get better. So just do it. You don't feel like talking because you're sobbing and you're an absolute mess and you've gone through like 5 hankies in 1 hour. It's all right. Just get through it, because once you do, the only way is on that other side, right? So that was difficult, talking when vulnerable. I still hate it. But yeah, like it just has to be done and you go through it. But yeah, it is work. And every time someone starts therapy, I tell my friends to kind of think of it as treatment. It is a safe space for you to talk, and it's safe, non-judgmental space for you to talk, but you're there for a reason. And I remember learning this at group, because I would come, and I think one day it was just like nothing's happening, and somebody else told me, yeah, because you never talk about anything. Like, for me, when I come to group, I know I have to leave with something, with some life lesson learned, and apply it during the week. And I think therapy also works that way, where, you do talk about things, you unravel things, but you get homework and you do the homework. And that you have to take it seriously. Like, I'm paying for this service and I'm going to get my money's worth, which is hopefully a life that I want to look forward to living, right? So yeah, it's effort and work, but it's worth it on the other side, because I feel actually like I quit drinking March 2020. So nearly 5 years, and I feel 5 years old. I like in these 5 years, I've just tried to do what I, have wanted to do, what life has stopped me from doing, like because of BPD. And I think I'm doing a good job because I have a list of like hobbies that I'm just like ticking through. I learned the piano, I learned Latin dancing, I performed in Goa. I started quizzing, I learned a little bit of Latin to help me with my quizzing. I have recently started sewing, which is what Pavitra was talking about. And yeah, and just yesterday I tried to repair one of my clocks on my own. I didn't, but I'll get back to it, I think. But yeah, I'm enjoying the time that I have now to do things because I'm not spending that amount of effort just getting out of bed or just grooming myself or just, I'm able to work. I'm able to take care of myself on my own. I live alone. I have a cat, so I'm taking care of her as well. And I have a solid group of friends. I don't have a partner, and I don't want one. So I'm happy on my own.
That was so heartening to hear, and thank you. But and I feel like that seems like a very, very heartening story of treatment and management. And I can see Ashlesha nod and say, "Yeah, I wish we could replicate this everywhere." But Ashlesha, I want you to talk a little bit about finding care, which is a big challenge, irrespective of the diagnosis in India, and especially for we've heard Aditi's story. It was up and down. It took her nearly 2 decades to arrive at this now. How does one really filter this? The world has opened up a little bit more. There's more information on the internet, more practitioners on the internet. And yet it's so important to find the person that is right for you. Do you want to come in on that, Aditi, as well first?
Yeah, I also want to ask Dr. Ashlesha to sort of elaborate the right kind of help, right? Because there are a lot of people claiming to be psychotherapists and counselors who are doing things that might be unhelpful as well.
So, I mean, it is very tricky in India, I feel. On the one hand, there is a lot of growth in the health sector. There's a lot of movement. There's a lot of desire to work in this sector. I mean, I know that maybe a couple of decades ago, not many people would have wanted to work in mental health. Even when I chose psychiatry, I remember I was working with Dr. Ajit Bhide at the time, who was a psychiatrist, and I had decided that I'm going to try and train in that. My parents called him for lunch and grilled him, said, "Oh, why is she choosing this field? Is it right? And, what if this affects her in some way?" So there's a lot of stigma many years ago, even in amongst health professionals, whether you want to do mental health or not. And that's moved a lot. And so much that it's also become a little bit of a buzzword where someone might have a successful career in something or the other and might choose to stop doing that, do a short counseling course and then start seeing people. Or they might do a coaching course and then start seeing people. And it's all right if they do that. I think that I know some of the counselors who may have a small amount of training, but actually quite good, as long as it's understood that their capacity to do something is limited based on the training they've had. And there are many, say, tiers of training. And a good therapist, in my opinion, is someone not necessarily who's very highly qualified, but someone who can connect with the person, approaches the person from their difficulties, and most importantly, especially for India, knows their own limits, right? And a good therapist who knows their own limits is going to be able to do as much as they can and then know when it's time to refer on. And if you have that, then that's a good start, I feel. So it shouldn't be that someone should only go looking for a PhD psychologist, because we know we don't have enough of those. So it's important that someone goes to a therapist who first builds on engagement, building a rapport, trying to understand that person, and do as best as they can in their level of understanding. And if it goes beyond their skill level, to then have that difficult conversation to say, okay, we need to find someone else for you. And that is not very uniform in India, I must say. And I do know many people, because when they refer to us, then they'll say, this is, and Sandeep is one of them. I think he's one of the best psychiatrists we have in Bangalore. And but he will sort of call and speak almost like a very humble student to say, okay, what do you think we should do? And he knows, he has a lot of knowledge, but just that humility is so important in any clinician. And so when we have someone who understands their limitation, and this can be true of even someone who's highly trained, they can reach their limitation, they could have the lack of skill for something. Like addiction, for example, it's not my specialty. And I may be able to do addiction comorbid with something else, but I know that, when someone comes to me for something that is out of my specialty, I'll be doing them a disservice by forcing myself to treat them or forcing them to see me. So I think that's one of the difficulties. And what I usually tell anyone who comes to me and then says, oh, I don't want to see the therapist anymore, they're not doing the right thing, which is great. They're able to recognize that they don't want to go back to that therapist. The first thing I tell them, if it's feasible, mostly it is to say, go and have this conversation. Because what you're telling me actually makes a lot of sense. And you shouldn't leave thinking that they're doing something right, but you are not, thinking clearly. So you're finding someone else. You need to go and tell them, hey, I don't like this, and this is not working for me, and have that conversation. Maybe that conversation will change the trajectory of therapy for you, and you might have a better relationship. Or maybe at least it will tell you that, yes, you have been able to tell them it's not working, and you're ending not because you are therapist shopping, or you're not ending because you couldn't do something. It's just that this was not right and you're ending on the right note. And then we look for someone else. And for many people, often it is that, unfortunately, like where you engage with someone, you do what you can, but also don't hesitate to recognize, like you trust the process, but you also don't hesitate to recognize that some aspect of the process is not working for you, and what can we do? And to be able to go back and have that conversation. And I have that all the time with my patients, which is therapy patients. And I know, like Aditi said, anyone who comes to our group therapy, all of them are on different level. So if they start comparing themselves, so why are you talking to them like that and me like this? Or why am I not able to get this fantastic job that Aditi got? So if they start doing that, which they may, but if they don't talk about it, if they don't address it, and I'm so glad, Aditi, you mentioned that someone told you, it's not helping you because you're not saying anything, right? And you might have gone away thinking that the therapy is not helpful, and or it's not working for you, or something's more deeply wrong with you, and all of that. Whereas if you said it's not working for me, or this is my problem, what do you all think, right? So it's really important to be able to do that, and that's a tricky one. I don't think people recognize the value in that.
From my experience, what I have found helpful about the team that's made me who I am, along with my effort and everything, yes. One is that, like you mentioned, Dr. Sandeep will ask, what do we do, right? And he always asks me, even when he's changing my medication or he's adjusting something, he says, so we have option A, B, C. What do you want to do, right? And very few, I feel that's the difference between Dr. Sandeep and the doctor who said, you need to quit drinking, right? And he includes you in the decision making, and that's like a great first sign. And another thing is, I think people think, even with feedback, and I've actually given this advice itself to a lot of my friends who tell me that I don't know if therapy is working for me. And, my therapist keeps saying this thing, which I don't like. And I said, well, have you talked to the therapist about it? And they say, oh, I'm allowed to do that, which you are, right? I think
Exactly.
especially, and not just with, psychiatry or psychology, but in any situation, right? Feedback is really important. And all the more in therapy. I think, I don't know if you remember this, Dr. Ashlesha, but you had worn this kurta this one day, which gave me some, it had a lot of zigzag lines, and I don't know, it just gave me like, I thought it looked like an optical illusion kurta, which is what I told her. And she took out a dupatta and she covered it. And she said, okay, I will not wear this kurta for therapy again. And you don't remember this?
No.
Okay.
I mean, I don't remember the kurta that you're saying.
Okay.
Yeah.
Okay. Yeah. So this happened. And I think it's just that simple, right? Like if something in therapy is bothering you about therapy, bring it up in therapy, because if you don't iron that, you're not going to move forward and actually get stuff done. But yeah, I think if something's not working for you, I guess address that, before just throwing out treatment away, okay, this didn't work for me. Yeah. I just wanted to add that.
That's such a valid point, that the treatment is not a one-way process. It's not prescriptive. And although, it is part of the nomenclature itself to say we give you a prescription, but even that is not prescriptive all the time. Which brings me to my next question very neatly and nicely, to say, if I were a person who's just received a diagnosis or not received a diagnosis, how would I go about treatment? And I think I would like for you, Dr. Ashlesha, to kind of move all the way to the different modalities that exist in terms of treatment itself. We talk a lot about this with our work at the PARC. We try to bring in, MBT and DBT and CAT and so on. A little bit of looking at what these modalities are. And the question that Aditi was really asking, to say, who decides? Does the client or the patient go say, I need MBT, I need DBT? Is this on their primary healthcare practitioner? Should they be making these suggestions? How do you really negotiate this very complex space? Because the answers they're not in a flowchart. There is a lot of if then else going on the side in terms of, treatment and management. So how can you try and simplify? I know it's not easy, but if you can, for someone who's just on the other side of this.
It's difficult in India because the bottom line, unfortunately, becomes you get the treatment that you have access to, unfortunately, right? And so if you don't have access to it, it's meaningless for you, whether it's A, B, C, D, DBT, MBT. None of that would make any meaning if you don't have access to that therapy. So, of course, for majority of Indian sort of people, it ends up being, can you get access to a good enough therapist, and start the work of starting to trust the therapist to overcome some of your main difficulties. Now, what we do know is that the main evidence-based therapies that are out there in sort of the entire world, I will say, and many people in India have started getting training for that, is dialectical behavior therapy is one of them, which Aditi was mentioning earlier. Marsha Linehan is the one who developed it, and it has a lot of those immediate skills, right? Like it's actually a very behavior focused therapy, which helps in managing emotions, helps in reducing risks, helps you to start building a relationship with your therapist. So a lot of the times when people with borderline personality disorder, because of the experiences they've had, whenever they're engaging in therapy, they're also inadvertently doing things without realizing, without intending to, which what we call as our therapy interfering behaviors, right? So DBT gives a model where you are improving your emotional regulation, you are reducing your therapy interfering behaviors, you are reducing your risks, self-harming, substance use, and it's a lot of tools are given to the person, right? So when you have these tools, then it makes it possible for you to get away from that constant survival mode to a space where you can then start really doing the next level of work. So DBT really starts off by giving you tools so you can cut down the self-harming, no pun intended, but, and start engaging with the therapist, reduce whatever dysfunctional ways of coping that you might have developed. And then when you get that a little bit of, not just going from one crisis to the next, then you start looking at addressing, your long form beliefs, like you said, what black and white thinking. And those get addressed with a lot of cognitive and mentalization based work. Now, in mentalization based treatment, what we do is we try and do that stabilization, or we even encourage people to make sure they're stabilized in individual therapy before they come to group, because they can't be just jumping from one crisis to another, or be in a very abusive environment. And if you don't address the environment, then nothing helps, right? So in our MBT group, we also run a kind of education and a model, group for the family members, so that we're not only treating the person. We are not saying that the problem is in you, you need to fix yourself. We're also saying they are learning ways of communicating. And you need to also maybe look at how you are communicating with them. Do you understand their difficulties? You might be doing something that's actually making things worse for them, or you might be doing something that's better, but they're not understanding. So mentalization-based therapy helps people to look at themselves from the outside, like how is everyone else viewing me, and it helps them to look at others' perspective as well, right? So that is the kind of it helps them to build better relationships. It helps them to reflect on their own self of what's happening, and it really starts reducing the intensity of the dysregulation. So dialectical behavior therapy is one of them. It's very behavior focused. Mentalization based therapy is more sort of exploratory and talk therapy focused. Now the other, and once you get them to a level of mentalizing, right, then they're perhaps similar to someone without BPD who might have had loss, grief, other things and trauma. Then you can do whatever work you do with anyone else. Then you're not faced with this mistrust of the therapist constantly. You're not faced with someone else in their environment invalidating them constantly. So then they're ready for the kind of therapy that other people can access because they didn't have those difficult behaviors. So at that point, really any long-term in-depth work would be fine. But it's getting them to that point is where a bulk of the work remains in therapies now. So DBT and MBT is one of them. Traditionally, a lot of the psychoanalytical spaces used to do a lot of therapy, and all the personality disorder would end up with psychoanalysis, right? Because they felt like this is long term. But there are newer, sort of transference focused therapies. One of the therapies that actually addresses borderline personality disorder in a more here and now. Because many times, if you try and just, go down to this edge of, or the depth of, like Aditi's example, and I'm so grateful, Aditi, the way you described your story. I felt like we should just listen to you and stop all these things that we're doing. But just, you're describing that experience of moving to Bangalore and what it was like for you. If a therapist sort of just goes to the jugular in your first or second appointment and you were abandoned by your parents, and before you even have the strength to recognize what that means, that can be very distressing. So you started exploring it when you had the emotional strength to do it. And that's what needs to happen. They need to build that strength, have a foundation where the deeper work can happen. So transference focused therapy is one of them. I don't know if many people in India are doing it. There is also schema focused therapy, which is a kind of cognitive therapy, which tries to understand people from different cognitive schemas. And there is emerging evidence for it. And I know people in India are training towards it. And there is cognitive analytical therapy, which I think is also very useful because it has models that are not just necessary in terms of talking. Like there is a lot of schematic work that can be done, diagrammatic work can be done, So I feel like and I'm guilty of that as well. We put a lot of emphasis on just talking and sharing and making meaning out of it, which of course needs to happen, but need not happen only with words. And in India, where not everyone has that language to say, I feel sad or I feel ashamed, they may not even have the language to recognize what's happening. Using other means can be very helpful, and cognitive analytical therapy does that. As to coming back to your answer of how does one go about it? I mean, ideally, one would hope that your first point of contact would be either a psychologist or a psychiatrist, and we would hope that the psychiatrist can do a comprehensive assessment and link you to the right person. And I must say that things have definitely improved in a lot of psychiatrists being able to recognize this better and starting to refer to what they think is a place for good therapy. And if they can then start accessing even just basic good therapy, which is, managing crisis, reducing the self-harming, they may use some DBT tools. They may not be a full-fledged DBT therapist, but they may use some DBT tools. And the sort of advantage of DBT is that a lot of people in India, from what I understand, have skilled themselves, not necessarily with the full Marshall Linehan training, but with just whatever resources are available easily, the tools. And that can be a start. And of course, unfortunately, the onus sometimes lies on the person to recognize, okay, this therapist doesn't know what they're doing, and but if they can find a psychiatrist or a primary physician whom they can trust, and then they can say, let's try this therapy, does it work or not, do I like this therapist? And the one thing that needs to work, whether the mode of therapy is right or not, is the therapeutic relationship. Like, you need to be able to talk to that person, you need to be able to trust that person. And what I tell everyone is, the first few sessions, maybe take 3 or 4 sessions. If you start feeling comfortable, that is important. Then you'll be able to tell them that you don't like something. You'll be able to have that If you're not comfortable, no amount of skill is going to help. So that should be the priority. And what we are also trying to do, like you mentioned in the PARC, is we are definitely trying to build the community of therapists who are trained in MBT. Our group, Aditi, I don't remember who was the therapist, my co-therapist at the time when you were in my group. Maybe it was Dharni. What we have done over the years is we've had other therapists observe us when we are doing the group. So they, after they observe us for a cycle, then they go and run their own group. And we're hoping that, we can build more networks of people getting trained, experienced, and running groups on their own. So that's happening in the MBT world, and we are hoping that it becomes more and more common and more people get trained in MBT. We're bringing people over to train as often as possible, and trying to make it, it's still not very affordable, but trying to make it as affordable as possible. I think it's the cheapest place in the world where people can get MBT training. But it's still, this is expensive for the clinicians, which means it is expensive for the people to get help. And I'm hoping the more noise we make about it, maybe whoever is looking at funding starts funding people to get treatment. So I feel like it's exciting times in India, but we have a long way to go.
I just wanted to add that to what Dr. Ashlesha was saying in terms of, as a patient, what to kind of do to maximize your what you get from therapy. One thing I realized that there's a lot of information out on Google in terms of all the tools are available. Everything you want is available on Google, DBT, CBT especially. And sometimes we may have tried these tools in certain sort of situations, and they may not have worked for us. So I think when a therapist recommends it again, it's easy to just say, no, this doesn't work for me, right? And I think because the knowledge is available to us as well, we may have the understanding that, I'm the one who's dealing with the disorder, and I'm the one who has to go through it. So I have knowledge about it, absolutely. But to not sort of try to micromanage the therapist, right? That, if they give you a tool to do, no, this doesn't work on me, please give me something else, right? Because it's possible that it's not worked for you with another therapist, but maybe this therapist has something new to bring to the table. And there is a little bit of control to be sort of relinquished in terms of trusting the therapist once you feel ready to do that. But if, for example, I remember my therapist used to prescribe a lot of body work in terms of, trying to sort of release tension and things like that. And I never really thought there was any, I didn't take it seriously because I was more focused on exercises that dealt with like cognitive restructuring and things like that. And I guess I personally didn't place a lot of trust in that basically area of using exercises like mindfulness and meditation and actual body movement exercises to help with relieving emotion, right? And so first few times I would say, yeah, okay, I'll do this, but not actually try it. And I think at one point I was just out of options, right? Because nothing was releasing, was making me feel like I was able to get this out of me. And it was in that moment that I tried body work for the first time, and it helped. And so there is, I guess, a tendency for us to sort of Google and find things and try them, maybe not in the right circumstance, Some tools work in some situations, they don't in other situations, but to keep an open mind and, trust your therapist to know if that, to know what they've studied, right? And we're not talking about getting a dental surgery or getting some sort of invasive procedure, right? We're just talking about using tools in different spaces. So there's no harm done in most of these situations where if they say, try to do something mindfully and you think, oh, that just sounds like some sort of new age thing and you don't want to believe in it, uh, it's fine. You don't have to believe that it will work, but there's no harm in trying it out. So to sort of not assume that because you've had the condition and you've been living with it for so long, I absolutely empathize, but no harm in trying new tools and let your therapist decide which tool you could use for what, and to just sort of keep an open mind and listen. Later you may try it and may not work. You were right, it didn't work for you, but there's no harm in taking that step to be open-minded and try it at least.
Thank you. Which sort of brings me to our last question to sort of wrap this up, to say, and I think both of you have covered it to a very great extent, to say, what does lifelong management look like? It's probably going to change in the next decade. But at this moment, what do you feel like are the core principles of management that you feel like you're at, Aditi, and then, maybe Dr. Ashlesha can respond to that.
So for me, I think, so right now, I recently just graduated from therapy again. So therapy for me has always been limited, time limited. Start with goals, and when we accomplish those goals, we fly solo after that. And because I think I actually like to compare it to having an injury, a muscle or a bone related injury, right? So you do physiotherapy to sort of strengthen it, and in case you need surgery, which I would equate to, say, medication, or something like MBT, which is like, very specialized. And so you do all of the treatment, but in the end, it's also about how you manage your life, right, with that injury. So I keep in mind that with BPD, I have limited energy. So I need to be mindful of how I'm expending that energy. So I have prioritized my mental health over everything else. That means no late nights. That means having to say no to parties sometimes. I am a recovering alcoholic, so there's no alcohol in my house, no matter how much somebody begs to just have one beer. No, it's not happening. These are my boundaries. So setting boundaries for yourself, and just prioritizing your mental health over everything. If exercise makes you feel better, great, you're exercising thrice a week then. And to just sort of be on top of things, sounds like a lot of hard work at first, but once you get into the groove, it just comes to you kind of naturally. And also to make choices, keeping all of this in mind, and readjusting your expectations. Don't compare yourself to people who do not face the challenges that you do. And I mean, like I said, there is hope, there's light at the end of the tunnel, definitely. But I also know that there are some things that are out of my reach at the moment, maybe. I will not stop, say, dreaming of saving up for international travel, but I will prioritize saving up for home renovations, because that's something I have to deal with on a daily basis. So to just be mindful of who's in your life, think about where or what you can make easier for yourself, especially when you're living with a condition that I feel BPD drains a lot of your energy, because emotion itself takes a toll on your body, right? And you're constantly like feeling every emotion inside and out. So yeah, to just, think of it as managing a factory, right? And resource management. So I have this much energy, this is how I'm going to use it. And I'm going to make sure I'm using my energy on things that make me happy. if I can spend a little time today doing something for tomorrow, tomorrow to feel better, I will. I have extra energy today. Fine, I'll do something for myself, right? So I think that's what I am picturing lifelong management to be like. Be realistic about what I can achieve, but dream a little as well, and uh, take it seriously. It's mental health is health. So yeah, and physical health impacts mental health. So take care of that as well. I think for me, of course, an added thing is to make sure the right information reaches everyone, and eventually care reaches everyone and becomes affordable. And maybe the eventual dream is that governments all over the world do something about um, making not just healthcare accessible, but also removing the stigma around, right? And being responsible, people in general being responsible with the things they say, and everybody working on themselves, not just people with mental illness, right? Because, okay, we know the heavy price that words can pay in terms of how we communicate with each other. But sometimes it would be nice if the people without illness also would do that.
Absolutely.
Like Dr. Ashlesha said, right? Like about having sessions with families. We're making the effort. So we'd like to see you to make the effort as well. So yeah.
Absolutely. I was gonna say I'm taking notes on things that I should be including in my life in this conversation, right? As in it seems like in many ways, okay, we should all be practicing this.
Yeah,
Absolutely.
just good. Like there's diet, like food diet. I think diet in everything, right? Mental diet. Are your friends adding value to your life? Uh, is is this something you absolutely need to do? Is this your expectation, or is it an expectation coming from Sharma ji ke bete or whatever, right?
Yeah, absolutely.
Yeah.
Absolutely.
Yeah.
Ashleisha, I'd like you to answer the question on management from your perspective, of course, but also include medication. I feel like we haven't really touched that very much. We have spoken about what's in the hands of
I'd
therapy.
like to add to that as well after
No?
Dr.
Yeah,
Ashlesha.
borderline personality disorder from a medication point of view has to be very, very symptomatic, and it shouldn't be done as a blanket. Let's put everyone on this medication. So I know that sometimes, like I saw someone for therapy who herself was a therapist and was, understandably quite anxious to try medication. Uh, so as far as I knew, throughout the time that I saw her, she may have been on a antidepressant for a very brief time, but throughout the time, she didn't take any medication. So there are many people who, if they're able to manage their crisis, or if they have the kind of support, they may not need medication. But primarily the medication that gets or has evidence is for the things that they undergo. So if someone has depression, or if they're very depressed, then they may need an antidepressant. If they have a lot of anxiety, then they may need something to manage that anxiety, again, an antidepressant. For many people, there is evidence for a mood stabilizer. But again, it's not like the mainstream treatment. Like you wouldn't just put everyone with the diagnosis on a mood stabilizer. Um, but and for a few people, antipsychotics can also be helpful, right? And of course, like if there is a comorbid condition, if there's substance dependence, then whatever is needed to treat that substance dependence, either anti-craving medication, or just to get them off, like, to help detox. So these are the things that are periodic in someone's life, but they're not long term. So medication, in my view, is like a crutch, because whatever is going on is so severe that they're not able to access or stay in therapy, or therapy is very painful. So we need to make sure the medication addresses that, so that they can then get to the main treatment, which is the therapy. In terms of long term, I mean, I loved what Aditi you're doing and what you say. I think that, in fact, I'm thinking it should actually go on policies, as to what should be long term management. But like the mental diet picture you said, it makes so much sense. And it's probably true for all of us, which we are not doing. Maybe we are all very complacent in thinking that I'm okay, I don't need to do this. But anyone with or without a mental health condition should be thinking, what are my vulnerabilities? What are my sort of, what is my Achilles heel? how do I draw a boundary? What do I do more of? What do I do less of? And figuring that out is, of course, much harder for someone who's had traumatic experiences, who's traveling through a maze of difficulties. So it's not just for them, it's for all of us, but definitely for them as well. One of the other things, and is helpful and we know has good prognosis, is when there is some constructive work or study going along. With borderline personality disorder, we know that if someone is in an employed position, or they're working, or they're studying, just doing something outside of the house, that is actually a protective factor. Because what I've been told, and like just watching the interaction between the two of you, what you felt in terms of Pavitra, and what Pavitra was recognizing, she's not your relative. No one's kind of forcing her to say these things. So when someone validates you just because they need to, like because your work is good, without any strings attached, that can be very powerful, right? You did something and that was appreciated. And that doesn't often happen for someone in the life of a borderline personality disorder, because either their family members are sort of saying, no, you're great, don't worry. They're trying to placate them, or they're trying to dismiss them. It doesn't feel genuine, like for people who don't believe that about themselves. But it's hard to dismiss appreciation that's coming out of nowhere. It's like, okay, you really think that was a good thing? So I feel like exposing yourself to a constructive thing is actually very protective. And in long term, we know that once the crisis is stabilized, if they get into something like that, that can be very helpful in terms of long-term management. And the most important thing that you're doing, like you said, Aditi, is recognizing who are the people you're surrounded by, and having the courage to sort of say, not okay, this is my boundary, and being okay with that. And if someone else is not okay with it, then they have to figure out, like the problem might be in them. Like, I'm doing everything, how you described it, I think that's important. And I think those are the kind of long-term things that can be helpful. And this is probably true of all of us, which is especially true for someone with borderline personality, is to recognize early sort of warning signs where they might start slipping, which for example, if someone knows that one of their vulnerability factors is travel, then they might have to take extra care when they're traveling, or when they're moved, or they might have to say, okay, this is a vulnerable time for me. For someone else, travel might be great, travel might be an escape. So for them, it's like, okay, I need to get back to my coping mechanisms. It's been a tough year, I'm going to travel. So for each one to figure out what are my early warning signs, get help early. And this formula that I think Aditi is following, you do short, brief, focused therapy. And this is actually what we are suggesting in MBT as well. I mean, 1.5 years is considered short in therapy world. To do that for 1.5 years, and then go away, use the tools, figure it out. And then if you need to come back when you're in crisis, come back and get a little bit of help and go back. So I think that model works much better, rather than staying in therapy for years and years, or taking medication for years and years. So you recognize your sort of vulnerability factors, you get help early, then get back on track, and then keep doing. And every crisis or setback, what I have noticed, and I don't know if this is the same for you, Aditi, is that it's a little less serious than the previous one. It also teaches you something. And as you grow, you might think, oh, I used to like to travel when I was younger, but that's not helping me anymore. I want to try something else. So you change your template as you go along as well, which is what we all should be doing. So these are the kind of things that really help in the long term.
So I wanted to add to the medication thing. I see a lot of people being very, hesitant about getting on medication. And I would say I have been on medication now, since 2013, not in the same dosage. I have tried it. It's constantly changing according to what my life is like. I lost a friend a few months ago, so which is how I ended up back in therapy, and that led to my childhood coming up, on its own. So I actually ended up feeling more depressed because of therapy, and then I had to have my medication dosage increased to help me through that time. And so I think one is, it's not go to the doctor, get a prescription. It's not like getting on statins or something, or iron supplements where, okay, I'm going to use this prescription and just keep refilling and taking. It has to be reviewed, right? And you have to keep going back and doing a back and forth. One thing is side effects. Sometimes there are, sometimes there aren't. I remember for a long time, I had the side effect of not having a libido, and which was fine at that time. I was actually coping with alcohol for that reason. And so when I stopped drinking alcohol and I was in a relationship, like our sex life went dead at that point. And so that's when I realized that, okay, now that I am strong enough to do this, I will change my medication. And so I went to the doctor, and it takes a while for that to happen. It's a process. Uh, Definitely some patience that needs to be, you need to have some patience and to get through it. But sometimes you say, I mean, you may think, or this is how I would approach it, is I weigh this thing of the side effect, right? For example, when I was on that medication which was killing my libido, at that time, I was more interested in not wanting to kill myself than sex. So it made more sense to be there. But when
Absolutely.
this is gone, then you think, okay, this is a problem I want to try, right? And so it really depends on where you are and what you want to prioritize. Because at the end, the medication has to be helping you. And I think a lot of people are also worried about being addicted to medication. And I think that's the problem for the doctor to figure out. Uh, I mean, Dr. Sandeep is always trying to keep me at the lowest dose possible. And yeah, I mean, maybe someday I'll be off medication. But for now, I am on medication because it's what's working. And in fact, in terms of side effects, I actually currently am not experiencing anything. And it's a new science. There's so many new medications coming out all the time. One medication may work for you for some time and then it stops working for you. Just, I think it's a lot of relinquishing of control, which is very hard to do, I know. But the results are great. And taking medication does not make you weaker in any way. We don't think twice about wearing glasses when we can't see. So I think it's the same thing. And, I feel that, yeah, mostly with people who experience depression, episodes of depression and anxiety from grief, loss, and things like that, where in anybody's life, I think there are 4 or 5 that they go through, right? Episodes. And they may be on medication temporarily and maybe off it. Important, I feel, for us not to compare ourselves to how much medication are they taking, how much, why am I being prescribed an antipsychotic when I don't have this thing. Leave those heavy scientific details to the experts. And if your doctor is not reviewing with you on your dosage, that's a red flag, right? That's when you may want to shift to a different doctor. But don't this medication out of, like, don't throw it out of the window because of these things and because of side effects, because all of this can be managed. New treatments are coming out. And yeah, always supplement medication with therapy. Because medication is, like I said, the surgery. It is going to help with the ligaments and putting them in place. But therapy is what's going to strengthen the muscle, right? So don't stop the therapy unless the therapist tells you, hey, you're good to go, then go for it. But yeah, don't be afraid to go back to it when you hit crisis again. Yeah. And it does get easier, like you said. I mean, I'm able to recognize when, like, I do feel when I'm in heavy moments of crisis, I still feel suicidal ideation, but I'm able to see that it's temporary and that it's just I'm overwhelmed by the emotion from the trauma, because that's just how my body is responding to it.
Yes.
So I'm able to, that awareness is there that it's happening around me and I'm not the storm. It's just around me and it'll go. That tolerance definitely builds, and it's great. Like, I have to thank you for that.
Thank you. Thank you so much. And I have to thank Aditi for all the analogies she's brought in to make this more accessible.
Brilliant.
To say,
Yeah.
okay, let's sort of take a break, take a hot moment and move away and say, let's look at this in the context of what everybody understands. But I think my big takeaway in this entire conversation is in many ways, psychiatric care and mental health care demands so much agency from the patient and their families. And I feel like this makes me hopeful that we're having this conversation. And maybe we'll move to a world and maybe a country where we do place a lot of agency in the hands of both the client, the patient, and their families. And this becomes a two-way conversation, which is really sort of what we're working at over here. Medical science in general can be prescriptive. It's, most of us feel very lost when we go to the doctors. And it's that much more when we're talking about mental health care. And I think that sort of jumped out at me to say that one of the reasons that we're listening to Aditi's wonderful story and why you have, put so much of yourself into this practice is because you strongly believe in the idea that there should be agency in the conversation, that it needs to be a two-way process. So with that takeaway, thank you so much. I hope this takes away many questions that people have on borderline personality disorder. Certainly worked for me. If you have more questions for either of our guests, we're going to leave an email ID in the description, and maybe some reading material work that both Ashlesha and Aditi have done for you to get a little more information in this space. But keep in touch, and thank you so much to the Zen-Brain team for inviting us to do this. I think a lot of things were unraveled for us in the course of this conversation.
Yeah, thank you so much.
For the platform also. Thank you so much. Thank you, Pavitra and Dr. Ashlesha.
Thank you.
Nice
Yeah,
to see
thank
you
you,
again.
Aditi. It was very nice.
Yeah.